Welcome to the deep dive. We take complex source material and, well, we boil it down for you. Today, we're diving into systemic autoimmune pathology. Specifically, we've got some great material here on connective tissue diseases. And our mission today is to really get to grips with one condition that's, well, it's famously tricky. Mixed Connective Tissue Disease, MCTD. Yeah, if you know anything about systemic autoimmunity, you know it's messy. You've got lupus, systemic sclerosis, polymyositis, each one complex on its own. But MCTD, that's the classic overlap, isn't it? It sort of borrows features from the others, creates this picture that can be really confusing. So we're going to focus right in on this specific hybrid condition. Okay, let's unpack it.
Right. And the definition itself kind of gives the game away, but also highlights the problem. MCTD, basically, it's defined by having clinical features that overlap with SLE lupus, systemic sclerosis, and polymyositis. So the patient looks like they might have bits of all three going on.
Bits of all three, okay.
But here's the crucial part, especially for diagnosis. The serology, that's the anchor. What's really unique, and you need this for the diagnosis, is very high titers of antibodies against U1 ribonucleoprotein, U1 RNP.
U1 RNP antibodies, high levels.
Extremely high levels. That specific signature is basically mandatory. It sets it apart, even with the clinical overlap.
Okay, so that antibody signature gives it an identity, even if the symptoms look like a mashup. But why that antibody? Why does attacking U1 RNP lead to this particular mix, lupus, scleroderma, myositis features, and not just, say, pure lupus?
That's really getting to the heart of it, isn't it? The mechanism. U1-RNP isn't just floating around, it's inside the cell nucleus. It's a key part of the spliceosome.
The spliceosome, right, that deals with RNA processing.
Exactly. It helps edit the genetic messages before proteins get made. So when the immune system goes after such fundamental machinery, well, it seems plausible it could disrupt things across multiple systems, leading to that mixed picture.
Oh, okay.
And if you look at why the overlap happens, that high U1-RNP titer seems to be the link. The thinking is these antibodies might drive the vascular symptoms you see in scleroderma, like Raynaud's, but also maybe contribute to the inflammatory stuff, like the joint inflammation. The Synovitis you see more in lupus.
So one faulty switch triggers multiple different warning lights.
That's a good way to put it, yeah.
Okay, let's talk about the patient then. What does this mix actually look like day to day? If you need features from three big diseases, what symptoms are we really talking about?
Well, it can vary a lot, of course, but there are some pretty common themes you see again and again. First, almost everyone gets Raynaud phenomenon, where the fingers or toes turn white or blue in the cold, that constriction of blood vessels.
Very characteristic of scleroderma, right?
Exactly. That's one major link. Then you often see Synovitis joint inflammation, especially in the hands and fingers. Swollen, tender joints. It can look a bit like rheumatoid arthritis or lupus arthritis.
But is it the same kind of destructive arthritis?
Usually not. That's a key point. It's typically non-erosive. So you get the inflammation, but not necessarily the long-term joint damage you might see in severe RA.
Got it. Non-erosive synovitis.
Hey.
And the muscle part? The polymyositis link. How does that show up? Is it just feeling tired?
No, it's more than fatigue. It's actual muscle inflammation myositis. Patients often get weakness in the muscles closer to the trunk, the proximal muscle, so difficulty lifting arms, getting out of a chair, that kind of thing.
Real weakness.
Real inflammatory muscle limpness. Now, the sources do say it's often milder than what you'd see in full-blown primary polymyositis, but it's definitely there.
Okay, so hand synovitis, Raynaud's, some muscle weakness, definitely sounds systemic. What are kidneys? Because kidney problems in autoimmunity, that's always a big concern. You mentioned lupus, severe nephritis can be devastating there. How does MCTD stack up?
Yes. And this is probably one of the most critical points for management and why catching MCTD matters. Renal involvement can happen in MCTD. The sources are clear on that. But, and this is the key word, it's typically modest.
Modest. Compared to severe lupus nephritis.
Exactly. Think about the really bad lupus nephritis, like class 4 diffuse proliferative nephritis, that often needs really heavy long-term immunosuppression. In MCTD, the kidney issues that do occur are often less severe, maybe more localized inflammation. And crucially, they generally respond pretty well to corticosteroids, at least initially. The prognosis from a kidney standpoint tends to be better, especially early on, than in severe SLE. It's a major difference in how you approach treatment.
Wow. Okay. So that U1 RNP signature potentially flags a less aggressive kidney course, at least at first. That's huge for the patient. But this brings us right back to that central question. If it borrows features and maybe some key features like the kidneys are often milder, Why is it still its own disease category? Why not just call it early lupus or early scleroderma?
Precisely. That's the identity crisis, as you called it. And it's a real debate that's been going on for a long time. You can basically break down the arguments based on following patients over time into two main camps. Camp one is the evolutionary subset idea. This view says, yeah, MCTD is often just a starting point. You follow these patients for, say, 5–10 years, and a significant number will eventually evolve. They lose some features, gain others, and eventually meet the full criteria for classic SLE or systemic sclerosis.
So it was just an early, undifferentiated phase.
That's the argument. It hadn't fully declared itself yet.
But then why argue it's distinct at all if it just turns into something else later?
Well, that leads to camp two, the distinct form argument. This side points to the other group of patients, the ones who don't evolve. They maintain that specific mix, the Synovitis, the Raynaud, the mild myositis, for decades. They never quite fit the box for full SLE or full scleroderma or full polymyositis. They stay in this overlap zone.
So some people stay in that hybrid state long term.
Exactly. And another point, the response to steroids isn't universal either. Some people don't respond as well, which complicates just calling it a milder early form. So the argument here is this persistent, unique combination of clinical features plus that defining high-titer U1 RNP antibody, maybe that does represent a truly distinct condition with its own natural history.
Right. It's the pattern, the specific mosaic that holds stable for some people.
Yes, that persistent pattern anchored by the U1 RNP.
Fascinating. It's like the diagnosis depends not just on the snapshot now, but on watching the whole movie unfold over time. Okay, let's try and wrap this up for everyone listening. The key takeaway here. MCTD is your classic overlap or hybrid syndrome. You get features borrowed from lupus, systemic sclerosis, polymyositis. The absolute must-have is that high level of U1 RNP antibodies. And critically, the kidney involvement is often, though not always, modest and tends to respond well to steroids initially, which is a big difference from severe lupus. Early diagnosis matters for management.
Absolutely. That management angle is key. Whether you believe it's truly distinct long-term or just an early phase, recognizing that pattern, finding that U1 RNP antibody, knowing the kidney disease is usually milder at the start, that guides your immediate treatment. It might mean a less aggressive approach initially. It gives you and the patient a different starting point, a different initial conversation about prognosis.
Excellent point. And maybe one final thought to leave you with, thinking about how this connects to broader autoimmunity. We know MCTD can sometimes evolve into SLE or scleroderma diseases where environmental triggers like sunlight or infections play a role. So if that U1 RNP antibody is there right at the start, defining MCTD, does its presence somehow set the stage? Does having that specific antibody mean your immune system is already sort of pre-programmed, influencing how it will react to later triggers, maybe pushing it down one path versus another? It makes you wonder how much is determined early on by these specific autoantibodies versus how much is shaped later. Something to think about. Join us next time for another deep dive.